We'll be continuing with the session ahead, which is the first oration, Professor John Ocean Oration. In 1973, Dr. Ocean was named the first recipient of the UT National Alumni Association Public Service Award. He served as the president of the UTHSC Faculty Senate and was chair Department of Molecular Biology. He was named Dean of the College of Pharmacy on August 1, 1975. He served as the dean until 1982, when he was named dean of the UT Graduate School of Medical Science. After retirement, Dr. Ocean worked tirelessly as an international humanitarian and health science educator and was proponent of the Memphis Biomedical Research Zone.
To add to that, I would also mention about Professor John Autian, that he had special interest in toxicology and plastics. So he was into material-vigilance in a big way, and which was fairly ahead of times, considering the time when he was into all these activities. And he was a great friend of India as well. He traveled almost 40 times to India, used to make it a point to attend the SoPICon every year till the time his health permitted, and was a great friend of Professor K.C. Singhal also. We lost him a few years back, but still his guidance, his energy, his drive, and his commitment to SoPI will always be remembered, and on his memory, this oration was started.
Thank you, sir. These are the previous orators for Dr. John Ocean Oration. They are displayed on the screen. And for today's oration, we have Dr. Vinod Kumar for us, who is an academic consultant for diabetes, aging, and geriatrics. Sir is the Emeritus Professor, St. Stephen's Hospital, Delhi, and WHO Geneva Advisory Panel. Sir is the patron, Indian Academy of Geriatrics, ex-patron, Geriatric Society of India. Sir has numerous awards to his credit, like the 9 Lifetime Achievement and many other awards from Government of India. Sir, I request you to come forward for your session. Can we please have a round of applause for sir?
स्लाइड इसी में है, बोल दीजिए। यही है, ठीक है, स्लाइड शो बटा, ठीक। Chairpersons Dr. Sandeep Kumar and Professor Rahman, Chief Guest Professor Vaiki Gupta, and my old friend Dr. Lalit Kumar from the same alma mater where I belong to. Yes, Dr. Gupta, I'm often associated for reducing the average age of the audience in successive conferences wherever I go. And in all those conferences, in terms of age, I'm always the single man odd out. So thank you for your compliment, and I would just like to say, because I have no association with the pharmacology. I have been a medicine professor, and I was just scratching my head. When did I read about pharmacology? And I remembered that in 1959, I got the first position in Agra University in pharmacology. So I thought there is some justification that I can give this oration. So the title that I have chosen is Disease Burden and Medication Challenges in Geriatric Population. I would divide my presentation roughly in 2 parts. First, I would try to make this audience understand what the geriatric morbidity is all about. Is it something only disease burden, or there is more than disease burden as far as the geriatric population is concerned? And in the second part, I would talk about the medication challenges. So this is the greatest triumph of the 20th century. That is a longevity revolution. We all know that geriatric population is increasing by leaps and bounds. Today, we have 150 million people above the age of 60 in India. And this statistics has been taken from the national policy of Government of India, which was promulgated in 1999 and later revised in 2000. And 11. As you will notice the upper bar, between 2000 and year 2050, the total population of India was projected to rise only to 1.5 billion, which is now today. It has come earlier than 2050. But as far as 60 plus population is concerned, it rose by more than 300% during the same period, from 76 to 324 million. And when we come to 80 plus, it has risen 7 times, 6 million to 48 million. So this is a scenario, and this is going to increase and increase in the times to come. Now, elder population, I think most people would realize, is the largest consumer of drugs worldwide. It has multiple morbidities of all kinds, and these are the settings where the elderly people require care, including pharmaceutical agents. We begin with self-care on the left lower side. They have to themselves care for self. They may require care at home, at daycare centers, of course, hospital care, palliative care, hospice care, end of life care, old age homes care, rehabilitation care, and nursing care. So these are the wide variety of settings of care where the elderly require being to be looked after. And you can imagine how many drugs they might be requiring in all these care settings. Now, these are the old age blues. This is a design this is something which I had designed few years before. It is now published also. I am of the opinion that elderly people do not simply have disorders. They also have symptoms without disorders. As they become old, they get many type of symptoms. And in between, there are other adverse situations. So apart from the fact that they have disorders, and I have alphabetically arranged the 10 most common disorders: arthritis, brain stroke, cancer, diabetes, elevated blood pressure, frailty, general dementia, heart and lung disease, infections. The list is incomplete, of course. But I am of the opinion that as you age, whether you have the disorders or no disorders, you keep getting vague aches and pains. You keep having cough in between. You are liable to constipation. Your appetite goes down. You feel fatigued, become forgetful. You have gums and teeth problems. You have hearing and vision problems. You lose your sleep. You have incontinence. So these are the aging symptoms that one must realize. And I'm trying to convince the medical profession that do keep these noted in your mind, not simply talk about the diseases. And these are the social and psychological problems. They have age discrimination. Societal attitude is negative towards them. They often suffer people going from their family away, in bereavement. And of course, I've told chronic diseases, depression, emotional disorders, income falling and the status falling, generational disconnect, healing and coping issues, and isolation and loneliness. So all this together puts a lot of burden on the elderly population. Now, these are geriatric syndromes. It is unique to the elderly population that they suffer from certain syndromes. These syndromes are conditions in elderly which do not correspond to any specific disease, but they complicate the care of older adults by interfering with their self-managing abilities and quality of life. There are many geriatric syndromes, but I have enumerated here 7. Each one is starting with the letter I. Impaired intellect is dementia. Immobility is due to frailty. Inappropriate medicines, polypharmacy, etc., that we are going to discuss today. Impaired vision and hearing. Imbalance leading to falls and fracture. Incontinence, urinary problem, and again insomnia. So, and often an elderly individual has many diseases in his body at the same time, and often he has more than one geriatric syndrome, and often he has aging symptoms, and he is also fighting with psychosocial, economic, and spiritual problems. This is what happens in old age. Slowly, he is likely to become dependent. He has mobility issue. He has a memory issue. He cannot bathe himself. He cannot feed himself. He has difficulty in visiting toilet. He cannot climb or come down the stairs, and he cannot even dress himself or groom himself. So, in view of all this, for last almost 100 years, the geriatricians have been grappling how to communicate such a complex scenario to a general physician and to the public at large. So this is the latest buzzword, which is called 5 M's of geriatrics. Although it is 5 M's of geriatrics, but it is now cutting across the senior aged patients in all the specialties, whether it is cardiology, whether it's oncology, rheumatology, everywhere. So this is what has to be always kept in mind. These are 5 most important problems of elderly, can be summarized. Mind, mentation, which covers delirium, dementia, and alertness, etc. Mobility, walking. Medications, we will talk. Multi-complexity means they have multiple diseases, geriatric syndrome, but they also have problems of finances and the living conditions, how they live, and what is the social state. And matters most, I think that elderly have to be asked, what are their aspirations? What is the goal of their life? They said that we don't want to live long. We want independence. We want a good quality of life. So that is all has to be covered. And now, so this is all about the communication, how do we communicate with the rest of the world what geriatrics is. Now, coming to certain drug challenges or medication challenges, I have enumerated, there are many, but I have enumerated 4 recent red flags which have happened as far as the drug usage by geriatric population is concerned. One is controversies in choice of drugs during COVID-19. You all remember elderly were the greatest victim of COVID epidemic or pandemic. And what all was happening, so many drugs came and come. They were repurposed, for example, hydrochloroquine, and there were other drugs like steroids or ivermectin, and all that. Those drugs came and went, and they were released on emergency authorization basis with limited clinical trials. They came and went back. They came and went back. So it was a huge chaotic confusion at the time of pandemic, which drug to be given to which patient, a COVID patient, for how long we should give, and even steroids. What was the timing to start steroids, for how long is steroids to be given. So it was all problematic at that time, and the elderly were the greatest victim of these controversies. Second, there is an increasing use of over-the-counter drugs of longevity. There are many longevity drugs, herbals and medications, and with false claims, not always true claims, and they are all available over the counter. This is a desire for temptation by the elderly themselves, and this is taken in a wrong perspective by the companies who are selling these drugs. And many of these drugs have side effects. So they can also cause adverse reaction. And this is again the second account of victimization of elderly from a drug point of view. Third is strong anti-vax lobby. I think in the morning, Professor Y.K. Chawla talked about electric current passing through esophagus when endoscopy done, and then it has been taken note of. Same thing is happening here as far as the vaccine is concerned. I think vaccine, pharmacologists say it is a mass medication, I think. So it's a kind of a mass medication. So strong anti-vax lobby, for particularly at the time of COVID and other times also, there is a cultural, religious and political barrier to various vaccines. I will tell you that. And the last but not the least, I think everyone has talked about it. Professor Y.K. Gupta talked about, and the director IPC in his virtual speech, he talked about semaglutide and things like that. So, and I'm invited almost every week to a seminar in Delhi dealing with obesity. And my knowledge of obesity, which was 0 1 year before, today it is 90%. But I have left going to these meetings at all. Now, this is the first example. I told you controversies in choice of drugs during COVID-19. And I have already told you that I did not, without trials, they were instituted, caused political rhetoric and social media information on issues, including their safety. And these are the drugs I was mentioning. This is the second one, increasing use of over-the-counter drugs. I have enumerated lots of longevity drugs. In fact, one of my areas of interest is longevity. And except metformin, I will name, it's a old horse antibiotic drug being used in this country for the last 60 years. It's still a more serious contender for anti-aging study. Some studies are going on. Other benefits of metformin are anti-cancer. They are for anti-Alzheimer also. It can be. It is claimed, and for polycystic disease of ovary, fatty liver, etc. But precautions are still there. Precautions include very advanced stage. It should be given with great caution. There are GIT complaints. There is reduced GFR where it cannot be given. Lactic acidosis, particularly in heart failure, elderly cases, and monitoring of B12 levels should be recommended. And if needed, B12 should be supplemented. This is the red flag as far as anti-vax lobby is concerned. Kindly confine your attention to the bold letters only, because this applies to elderly. Influenza, DPT, and meningococcus. They say that GPS. Now, people have been always alerted that it can cause Guillain-Barré syndrome, but the evidence, scientific evidence, is statistically insignificant. Second is hepatitis B, which has been associated with multiple sclerosis. A strong anti-lobby for that, but it is unfounded. And last is COVID-19 vaccine. Rare thromboembolism, DVT, you have all heard, but vaccine benefits far outweigh the risk. This is number 4. This is something I will spend a minute. Yes, it is true that weight loss drugs, GLP-1 agonist, semaglutide, liraglutide, or tirzepatide is a game changer. Truth or hype, Professor Gupta said about young ladies making a beeline to get these drugs. And this goes by the name of GLP-1 bride, Munjaro bride. That is the name which is often given to these ladies. Similarly, but as far as I am concerned, there are specific issues of elderly, and I think so. As far as the elderly is concerned, they all say that there is no upper age limit for using these drugs. But clinical trials without which have taken place, they are without adequate number of elderly. That's number one. Number two, GLP-RAs work best only with robust lifestyle changes. Lifestyle changes means not only increasing the protein intake, reducing the calorie, but also doing aerobic brisk walking and also strengthening and balancing exercises. It's a tall order for elderly to stick around. Third is changes are happening with the treatment, whatever treatment you give them, then they tend to lose muscles further, and it is very dangerous for the elderly people to lose muscles, because then there are so many fatigue issues. Their insulin will not be able to work for bringing the blood sugar under control. And lastly, very importantly, everybody says that there is weight regain once you stop. So how long you can give? People have been giving trial for 72 weeks up to sometimes 84 weeks. So hence a lifelong treatment. But elderly who have only a limited life, how relevant it is for a lifelong treatment. So this is like Munjaro bride. This is the Ozempic phase. When you take Ozempic, this is the kind of phase you develop. Many celebrities in Mumbai and others, they have Ozempic phase. So it sunken eyes, wrinkles, and wrinkles. Already elderly people are averse to wrinkles, because elderly people say, when I was young, I used to worry about my pimples, but when I was old, now I'm worried about my wrinkles. So by giving these drugs, you are going to increase their wrinkles. So semaglutide, here I am just trying to tell you that as far as the STEP trial is concerned for semaglutide, the number of people who were the above age of 75 years in the clinical trials, only 1% of participants. So on this basis, can you justify the use of these drugs? And they all say, because they are partly trial by the pharmaceutical company, so safety, efficacy, and outweigh, they all seem to be satisfactory. So I won't give much detail on this slide. Same is the story of liraglutide and tirzepatide. Yes, there is a change in weight. There is a loss of weight. Yes, there are not many side effects. But as far as the liraglutide is concerned, the yellow triangle shows possible increase in side effects for older participants. So I come back to this. And now I will talk about the whatever other medication challenges are concerned. So this, I don't think I am qualified to talk about this slide at all in front of such a august gathering, rational drugs. So I will skip it. These are the barriers to rational drug prescribing as far as elderly are concerned. Impaired physiology they have. They have different pharmacokinetics, pharmacodynamics. Their volume of distribution of drugs, both for fat soluble and water soluble, is abnormal. They have multi-morbidity, load and geriatric syndromes already I have alluded to. And they go to multiple specialists because they have different kind of diseases. If they have heart disease, he'll go to cardiologist. They don't think of going to geriatricians because geriatricians are also they are still in the making as far as our country is concerned. And because of multiple specialists, they are prescribed multiple drugs, and that they may become victim of polypharmacy. And many of them they try homeopathy, Ayurvedic, indigenous drugs, and they also are subject to dosage errors due to their impaired cognition and psychology. And of course, this is the source of adverse. So these are the drugs to be avoided, particularly in elderly: anticholinergics, psychotropic, opioids, strong hypoglycemic agents, and some other high-risk drugs are alpha blockers, chronic use of NSAIDs, PPIs for more than 8 weeks, unless necessary, should not be given, antiviral digoxin. But these do not apply when the elderly is in hospice care or end-of-life care. Examples of drug-drug interactions, some examples, there are many more. These are the NSAIDs, ACE inhibitors can cause hyperkalemia, also loss of efficacy of ACE inhibitors. Thiazide and carbamazine together increase the risk of hyponatremia. NSAID, sulfonylurea together aggravate hypoglycemia. Digoxin, persamide, amiodarone, digoxin toxicity, and so on. So deprescribing, again, this is I think you are better advisor and then than anyone else. But this is a patient-centered intervention with inherent uncertainties and requires shared decision-making, informed patient consent, and close monitoring effect. It's a very difficult choice when you want to prescribe some drugs on elderly. I know one elderly individual in USA who was taking 20 drugs, but they were gradually and scientifically reduced to zero. He didn't require anything, and he lived up to 100 years. Now, these are the indications for de-intensification therapy. Here, I'm not very sure what is the difference between these prescribing and de-intensification, but I think de-prescribing means you are stopping one of the drugs, and de-intensification means you are reducing the dose of the drug, something like that. So these are the indications where de-intensification should be tried. Dementia, very advanced age, impaired renal or hepatic function, when there are numerous comorbidities, tight diabetic control indicated by less than HbA1c less than 7, or end of life quality, life expectancy expected is only less than 1 year. There is frailty, or he's already on inappropriate medication, and if he is diabetic, the duration is very long. Now, some numbers about polypharmacy. Sweden, polypharmacies and excessive or heightened polypharmacy, the numbers are given here. In US, the same numbers are given here. And these are the numbers in India reported from some of the studies. Pooled prevalence, 49%. Hyper polypharmacy, that's more than 10 to 31%. Potentially inappropriate medication with ineffectiveness or high-risk benefit, 28%. This is a graph which I am carrying for quite many years. This is about diabetes, polymorphous. If you confine your attention to the orange bars in between the two orange bars, you'll find that diabetic patients, they are about 35% of diabetic patients are on 1 to 4 drugs, but 50% of diabetic patients are on 5 to 9 drugs, and 10% of patients are even taking more than 10 drugs. So polypharmacy together, prevalence is about 60% among diabetics. Polypharmacy increases the risk of poor diabetic control, hypoglycemia, and may have a risk of falls, hospitalization, and death. These are the consequences of polypharmacy. Here I would draw your kind attention to they aggravate geriatric syndrome like cognition, falls, fractures, and hospitalization. And these are some of the warning signs for a general physician. They could be autonomic like hypoglycemia, orthostatic hypotension, syncope, CNS symptoms like lethargy, confusion, dizziness, somnolence, or extrapyramidal symptom, GIT like dry mouth, diarrhea, constipation, and bloating, and cardiovascular symptoms like tachycardia, CHF, and edema. So this is the pill burden. One of the patients who is a known case of osteoarthritis, hypertension, type 2 diabetes, IHD, BMI 36, complained recently of pain, weakness in both knees, joints, and pedal edema. This is the long list of drugs. So how it is solved? Solved by simplifying the drug regimen so that he can understand, caregiver can understand, through fixed dose combination possibly, switching to once daily dosing, conducting regular medical reviews to eliminate unnecessary drugs. The strategies are again de-prescribing and addressing the polypharmacy to improve compliance and quality of life. Now, this is another issue. Elderly people, particularly who are less informed in the society or those who are living in rural areas, they have what is called a fatalistic attitude. कहते हैं अब तो भगवान का सहारा है, अब हमें क्या जीना. This attitude is a very detrimental attitude. According to certain social scientists, only 20% is medicine and 80% is attitude. That is what social scientists say. It's an overstatement, of course, but I would say that this fatalistic attitude, together with many other factors like unaffordability or other kind of issues, they have no escort to carry on, they have cognition defect. So there are multiple factors which throw these people into non-compliance. So these are the factors I have enumerated left side, and on the right side, how we address these factors. But I will come to the same slide in terms of diabetic patients, which is a very common disease. So non-compliance to anti-diabetic drugs is about 40%, which further increases with increasing age. Unsatisfactory diabetic control seen across all ages in our country is in among 65 plus people is more than 7%. They are not controlled. So fatalism to be addressed by counseling, affordability to be addressed by cost-effective treatment, cognition by brain-challenging activities, polypharmacy by, again, de-prescribing or de-intensification, geriatric syndromes by screening and treating them, depression by detection and treating them, social support by having a good caregiver, and sensory optimization, again, by having a good caregiver. So that is all what I have to say. I hope you enjoyed. Thank you very much.
Thank you so much, sir, for such an informative session. Do we have any questions?
No. First of all, there are no questions in oration. And let the chairpersons conclude.
Okay.
So thank you so much, Dr. Vinod. It was really wonderful to. It was really wonderful to hear you, and you're the best person, obviously, on this topic to deliver the John Autian Oration. Now, the society is indebted to you that you have accepted our invitation and delivered this lecture. So, since there is no question on usually on orations, but sir, I would like to add one thing. Professor Bhai Gupta knows this thing. I have a manuscript on geriatrics, which was written around the 16th century. Geriatrics, and that was written by Al-Harawi. He was a scholar who came from Herat, Afghanistan, during the time of Babur, the first emperor of the Mughal Empire. And he wrote a book on geriatrics, which is called as Anul Hayat. The title of the book is Anul Hayat. And this has been translated into English also by me. And Indian National Science Academy basically given me a project on working, and I did a meta-analysis of geriatrics like for the last 600 years, how many works have been done on geriatrics. So I think this is, I don't know if you know this about this textbook. It's first documentation on geriatrics. I'll present you the hard copy because I translated it into English.
on PG. That book has 10 sections, including medical care, social care, biological, the financial people that is for most libraries.
Yes, yes.
Need to write a comprehensive
Ji.
not the just mention.
I know, yeah. But sir, it's very surprising that 600 years before he was writing about gerontology and genetics, and he was mentioning the reasons of old age, the physical deterioration, why the physical deterioration occurs in the old age. Like, and he had written something, 164 intervention, not only diet, lifestyle, and where to live, and what to eat. So it's very interesting, I think, for you. That's my comments only. Thank you so much.
So
I request our chairs to felicitate Dr. Vinod.
thank you very much.
Oh. Sir, आ रहे हैं sir अभी. Okay, we'll be going ahead with the second oration, which is Professor K.C. Singhal oration.